Hi, it's your student nurse Kim again, and for today's video, we will be talking about urinary tract tumors, specifically the upper urinary tract cancer. In this video, we will be covering its definition, pathogenesis on how the disease developed, clinical manifestation, diagnostic and laboratory procedure, treatment modalities, medical management, nursing diagnosis, nursing management, as well as prognosis. And if you want to learn about urinary tract tumor, please do keep on watching and let's jump to the video. Okay, so before we identify those abnormal cells that can be found in the urinary tract, let us first define what cancer is. So cancer is when cells in the body grow out of control, often forming a mass or a tumor. In upper urinary tract cancer, abnormal cells are found in the renal pelvis where urine collects in the kidneys before it travels to the ureters and bladder. Renal calyces where it is found in the spaces deep in the kidneys. And ureters, which is a thin tube made of muscles which moves urine from the kidney to the bladder. Since the exact cause of this cancer is not known, it is difficult to prevent. Still, there are certain risk factors that are known to affect cancer development. And what are those? So first is we have the gender. Upper urinary tract cancer is diagnosed in men 2 times more than in women, but women have a 50% greater chance of dying of this cancer. The second one is the race. Experts are trying to understand the role of race in upper tract cancers. Like bladder cancer, upper urinary tract cancer is less common in African Americans than whites, but it's more deadly. Another one is the age. As with bladder cancer, upper tract cancers occurs most often in people older than age 70. It is rare in those younger than age 40. Next is smoking. There is a strong link between renal pelvis and ureteral cancers and tobacco use. If you have been a smoker, your risk level is tied to the number of years you smoke. Unlike lung and esophageal cancer, the risk of upper urinary tract or bladder cancer will remain high for decades. Likewise, non-smokers have a much lower level of risk for these cancers. Chemicals in the workplace also do play a role in the development of cancer. Exposure over time to chemicals used to make plastics, textiles, leather, and rubber can cause cancer. Other risk factors include long-time use of large amounts of painkillers, certain herbs used to help you lose weight, previous blood cancer, and also previous urothelial cancer treatment in smokers. For the last risk factor, which is genetics, there isn't a lot of proof connecting upper urinary tract cancers to family history. However, in a small number of cases, there are clear genetic factors. So if you have urothelial cancer, your family members could be at higher risk. Family members should avoid the risks such as smoking. For the pathogenesis, the most common of all upper urinary tract cancers are those found in the renal pelvis and renal calyces. Cancer in the ureters makes up about a quarter of all upper urinary tract cancers. Tumors of the renal calyces, renal pelvis, and ureter starts in the layer of tissue that lines the bladder and the upper urinary tract called the urothelium. Cancer that starts in the urothelium is called urothelial or transitional cell cancer. This is the most common type of cancer found in the bladder as well. Because many of the organs in the urinary system share common cells, cancer found in these organs often look and act alike. The urothelium is special in the way that it swells and shrinks to push the urine through the urinary tract. Because it is in direct contact with the urine, this lining is exposed to chemicals called carcinogens, which are filtered out of the blood by the kidneys. These chemicals can cause cells to change and grow out of control as cancer. Because the bladder stores urine, it may be at greater risk for cancers than other parts of the upper tract. Its cells are exposed to harmful substances for a longer time. When urine has a high percent of harmful chemicals, cancer may also grow in the kidneys or ureters. For the clinical manifestations, a patient may experience hematuria, blood in the urine. Blood in the urine is the most common sign of upper urinary tract cancer. As a rule, it is painless, but since it can happen with a variety of urinary tract problems, your healthcare team should check for all likely sources of any blood found in your urine. Next is pain. You may have no symptoms if the tumor is growing slowly. An X-ray or ultrasound may be the only way to see whether a slow-growing tumor is present. If the tumor is fast-growing, it could cause pain by blocking the kidney's collecting system. This could cause nausea and sharp pain in your lower back, side, or stomach. Since these are also signs of kidney stones, you should see your urologist right away. So here are the less common complaints. Weight loss, anorexia, and bone pain may be signs of advanced disease. A mass in your side or abdomen can also be signs of advanced disease. For the diagnostic and laboratory procedure, first is we have the medical history and physical exam. If your primary doctor feels that you should see an expert, you will be referred to a urologist. The urologist will ask a variety of questions about your health history and will check your body with a variety of tests. He or she will feel your belly, sides, and back for lumps and will order blood tests. A microscope exam of cells in the urine, which is called cytology, can help find an upper urinary tract cancer. Sometimes, normal urine from the other kidney can water down a sample, making cancerous cells hard to find. If your doctor suspects cancer or cannot find the source of blood in the urine, he or she may order imaging tests. Okay, for the imaging, we have the ultrasound and computerized tomography scans. So these are painless, non-surgical ways to check the urinary tract. But while CT scans can show stones in the kidney and ureter, they are less useful in showing tumors. To see tumors more clearly, the doctor may use a contrast dye with the CT scan. To check whether the cancer has spread to other organs, MRI or the magnetic resonance imaging may also be useful. Adding a retrograde X-ray using a special dye may be needed if you have poor kidney function. Next is cytoscopy. If the source of bleeding is still in doubt, your doctor may order cytoscopy. A cytoscope uses a special fiber optic tool like a camera lens to look through the urethra into the bladder and urinary tract. Next is endoscopy or ureteroscopy. If the urologist needs more information, he or she may do a direct visual inspection of your upper urinary tract. This is usually done while you are under anesthesia. An endoscope, a scope with a light attached, is inserted through the urethra into the bladder. It is then moved up to see inside the ureter and renal pelvis. If needed, the doctor will remove a sample of tissue to help in diagnosis, which is commonly known as biopsy. In imaging for metastasis, if the urologist has a confirmed cancer diagnosis, he or she will check to see if it has spread. If urinary tract cancer cells are found in other sites, it is called metastatic cancer. So here are the tests to see if the cancer has spread to common sites, which include the CT scan, specifically the abdomen, the pelvis, the nearby lymph nodes and organs. Next is MRI, chest X-ray to look at the lungs, bone scan to look at the skeleton. Moving on with the grading and staging. If cancer cells are found, your doctor will need to know the tumor grade and stage. Understanding this will help your healthcare team develop your treatment plan. Okay, for the grading, the grade tells how fast a tumor is likely to grow. The most widely used grading system grouped tumors into two main grades, the low and high. For the low grade, tumors grow more slowly. They often come back after treatment, but rarely get into the upper urinary tract wall. They also don't tend to spread to other parts of the body. And as for the high grade, tumors grow more quickly. They often come back after treatment and more likely to other parts of the body. Moving on with the staging. Your doctor must also learn how deeply the tumor has gone into the collecting ball. This is called staging. Your doctor also wants to find out if the tumor has spread to other parts of the body. In general, the higher the stage number, the more serious the cancer. Often the stage is not clearly defined until the tumor is removed and studied by a pathologist. So it is an expert who looks for cancer cells and tissue samples. Okay, for the stage 0, we have 2, which is the non-invasive papillary carcinoma and the carcinoma in situ. So for the non-invasive papillary carcinoma, abnormal cells are found in the tissue lining, the inside of the renal pelvis or ureter. These abnormal cells may become cancer and spread into nearby normal tissue. Non-invasive carcinoma in stage 0 may look like tiny mushrooms growing from the tissue lining, the inside of the renal pelvis or the ureter. For the carcinoma in situ, which also belong in the stage 0, abnormal cells are found in tissue lining, the inside of the renal pelvis or ureter. These abnormal cells may become cancer and spread into nearby normal tissue. Stage 0 or carcinoma in situ is a flat tumor on the tissue lining the inside of the renal pelvis or the ureter. For the stage 1, cancer has formed and spread into the lining of the renal pelvis and or ureter into the layer of connective tissue. In stage 2, cancer has spread through the layer of connective tissue to the muscle layer of the renal pelvis and or the ureter. Next, for the stage 3, cancer has spread from the renal pelvis to tissue or fat in the kidney, or from ureter to fat that surrounds the ureter. And last one, the stage 4, where cancer has spread to at least one of the following: the nearby organ, the layer of fat surrounding the kidney, one or more lymph nodes, and distant parts of the body such as the lung, the liver, or the bone. For its treatment, what you and your doctor choose depends on many issues, such as the tumor grade, how aggressive the tumor is, the tumor size, the location and the extent, your age, medical history, overall health, kidney collecting system anatomy. So options include surgery, chemotherapy, and radiation. So let's start with the radiation, which belongs to the treatment modalities. So a high energy radiation is used to destroy cancer cells with minimal damage to nearby organs. Radiation is rarely used for urothelial tumors since the area to be treated is so small and hard to target. Your doctor will only use radiation if he or she can avoid damaging nearby tissue. For the medical management, we have chemotherapy. So under this is we have the topical chemotherapy and immunotherapy. In bladder cancer, drugs can be inserted in the bladder to prevent cancer from coming back, but they are not often used for renal pelvis or ureteral cancer. The bladder holds fluid for hours, so the tissue has plenty of exposure to drugs. But the upper urinary tract doesn't hold as much fluid as the bladder, or for as long. Still, your doctor may use drugs in addition to surgery. Next is the systemic chemotherapy. Chemotherapy uses drugs to kill cancer cells. It may be used to treat upper urinary tract cancer before or after the kidney and ureter are removed. You may receive chemotherapy in different ways. One thing is by mouth. So some drugs are pills that you can swallow. They may be given before or after surgery. Another one is into a vein, or what we call intravenous. The drugs enter the bloodstream and travel throughout your body. Chemotherapy may be given before or after surgery. You may have your treatment in an outpatient part of the hospital, at the doctor's office, or at home. Rarely, you may need to stay in the hospital. Chemotherapy is usually given in cycles. Each cycle has a treatment period followed by a rest period. If the drugs are given by vein or taken by mouth, the side effects depends on mainly on which drugs are given and how much. Chemotherapy kills fast-growing cancer cells, but the drugs can also harm normal cells that divide rapidly. Like blood cells, when drugs lower the levels of healthy blood cells, you're more likely to get infectious, bruise, or bleed easily, and feel very weak and tired. Your healthcare team will check for low levels of blood cells. If your levels are low, your healthcare team may stop the chemotherapy for a while or reduce the dose of drug. There are also medicines that can help your body make new blood cells. Next is cells in hair roots. So chemotherapy may cause hair loss. If you lost your hair, it will grow back after treatment. The color and texture may be changed. Last is cells that line the digestive system. Chemotherapy can cause a poor appetite, nausea and vomiting, diarrhea, or mouth and lip sores. Your healthcare provider can give you medicines and suggest other ways to help these problems. They usually go away when treatment ends. Some drugs used for upper urinary tract cancer may also cause tingling or numbness in your hands and feet. Your healthcare can suggest ways to control many of these side effects. For the surgical management, first is we have the removal of kidney and ureter. The majority of upper urinary tract cancers are treated with nephroureterectomy, which is surgery to remove the kidney and entire ureter. The radical form involves removing nearby lymph nodes and tissue as well. Since you will only have one kidney, your doctor will closely watch your overall kidney function. You would not need dialysis unless you already have serious kidney problems. The type of surgery you are offered will depend on surgeon preference, the tumor size, the tumor location, and tumor aggressiveness. Options include the traditional, a 10-inch cut into the abdomen is made to remove the tumors. The laparoscopy, tube-like instruments are inserted into the abdomen through small keyhole cuts. So next is kidney sparing surgery. In kidney sparing surgery, your doctor will try to keep the remaining kidney and ureter on the side with the tumor. This is an option if you already lost a kidney to cancer, lost a kidney because of stones, infection, or trauma, kidney problems because of diabetes, high blood pressure, or glomerulonephritis. If your doctor decides to spare the kidney, the tumor can be managed with segmental resection or endoscopic removal. For the segmental resection, this is done by removing the cancerous part of the urinary tract and then reattaching it so the kidney is still joined to the bladder. This is done if the cancer hasn't spread past the surface. Next is endoscopic removal. This is actually done by removing the tumor through a small scope called ureteroscope. Ureteroscope is inserted through the bladder into the upper urinary tract. Then the tumor can be destroyed with a laser. This is done if the growth is small and low grade. For the last one, which is the percutaneous tumor removal, a scope is placed directly into the kidney's collecting system through a small puncture in the back. Okay, for the nursing diagnosis, we primarily have acute pain related to activity of disease process, cancer. Another is anxiety related to underlying pathophysiology response, change in health status. Evaluation criteria in acute pain, patient will verbalize relief or control of pain. Client will appear relaxed and be able to sleep and rest appropriately. For the nursing intervention in acute pain, first is we have to assess pain level, location, characteristics, and intensity. So the rationale behind this is it helps evaluate degree of discomfort and effectiveness of analgesia or may reveal developing complications. Pains in surgical causes usually subside gradually as healing begins. Continued or increasing pain may be a sign of infection. Second is listen to patient's fears and concerns. Stay with him during periods of severe stress and anxiety and provide psychological support. So the rationale for this is reduction of anxiety and fear can promote relaxation and comfort. Next is encourage and maintain bed rest during acute phase, if indicated. So the rationale behind this is it minimizes stimulation and promotes relaxation. Last is administer analgesics as indicated. So this may reduce or control pain and decrease stimulation of sympathetic nervous system. For the second nursing diagnosis, which is anxiety related to underlying pathophysiology response, change in health status. So for the nursing outcomes, a patient will verbalize awareness of feelings of anxiety and healthy ways to deal with them. Patients will report that anxiety is reduced to a manageable level. Patients will express concerns about effect of disease on lifestyle and position within family and society. Patient will demonstrate problem-solving skills and effective coping strategies and use resources or support systems effectively. Okay, so for the nursing intervention of anxiety, observe behavior indicative of anxiety which can be a clue to client's level of anxiety. Another is explain purpose of test and procedure in bladder cancer or in upper urinary tract tumor treatment. So rationale for this is that it reduces anxiety attributable to fear of unknown diagnosis and prognosis. The third one is encourage family and friends to treat client as before. So this reassures client that the role in the family and business has not been altered. Next is administer sedatives and tranquilizers as indicated. So this may be desired to help client relax until physical able to reestablish adequate coping strategies. So for the last one, review coping skills used in past and identify coping skills the individual is using currently, such as anger, daydreaming, forgetfulness, eating, smoking, lack of problem solving. So this may be useful for the moment, but may eventually interfere with resolution of current situation. Okay, for patient teaching and home health guidance, so tell the patient what to expect from diagnostic tests. For example, make sure he understands that he may be anesthetized for cystoscopy. So after the test results are known, explain the implications to the patient and his family. Next is demonstrate essential coughing and deep breathing exercises, which is very important. In patients with orthotopic bladder replacement, teach the patient how to irrigate the Foley catheter. Suggest the use of leg bag during the day and a Foley drainage bag at night. Once the pouch has healed and the Foley catheter, ureteral stents, and pelvic drain has been removed, teach the patient to push or bear down with each voiding. For the prognosis, upper urinary tract cancer is diagnosed in men 2 times more than in women, but women have a 50% greater chance of dying of this cancer. So that ends my video presentation. I hope you guys learned something and thank you so much for watching.